A very good morning, everyone, and thank you for joining this year's IPSNIC Basic Sepsis course. So for this session, over the next 20 minutes or so, we'll be talking about the epidemiology of pediatric sepsis beyond 2020. What have we learned? My name is Jen Hao, and I'm currently working as a senior consultant in the Children's Intensive Care Unit at KK Women's and Children's Hospital in Singapore. For this presentation, I have no conflict of interest to disclose. The three main learning objectives for this session is number one, to understand the global epidemiology of pediatric severe sepsis and septic shock. We will also learn and describe the differences in outcomes between various regions around the globe. The second objective is really to describe some of the recent evidence about vulnerable patient groups that we see in our ICU who had severe sepsis and septic shock. And finally, we will have some time to describe potential interventions that may be able to reduce the burden of pediatric sepsis. The World Health Organization has recently adopted a resolution to reduce the global burden of sepsis through early identification, prevention, and management. Indeed, sepsis is the leading cause of death in neonates and children compared to adults. Fortunately for us, sepsis is highly preventable. However, the global pediatric mortality risk remains poorly described. And in the first session of this talk, we will describe some of the global disparities in pediatric sepsis mortality. Before we describe the epidemiology of sepsis further, we need to be mindful about the challenges in defining severe sepsis or sepsis in children. This slide shows the most commonly used definition of pediatric sepsis in many studies in the medical literature. The International Pediatric Sepsis Consensus Conference definition was first described more than 15 years ago, and it uses the criteria of the Systemic Inflammatory Response Syndrome or SIRS together with the presence of an infection or a suspected infection to define sepsis. These four pictures here show fairly common conditions that we see in our ICU: lobar pneumonia, meningococcemia, dengue fever, and viral pneumonia. No doubt, these four clinical phenotypes will satisfy the criteria for sepsis based on this definition. And one may argue that are they really similar or are they different? Nevertheless, despite the limitations of this definition, many studies have used this definition successfully in describing the epidemiology of sepsis that we have to date. So let's take a closer look at what is being described in the literature on the global epidemiology of sepsis. So this systemic review that was performed approximately 4 years ago focuses on population-based studies. In this review, the investigators included 23 studies, 16 from high-income countries, 7 from middle-income countries, and of note, there were no studies from low-income countries. 6 studies were on sepsis, 5 were on severe sepsis, and 8 was based on neonatal sepsis. The investigators found that sepsis is fairly common based on population studies, and sepsis happened in about 48 episodes per 100,000 person years, of which approximately half were severe sepsis. And this systemic review reported that there were approximately 22 severe sepsis per 100,000 person years. Because the prior systemic review only utilized population studies, we wanted to widen our net to include other study designs such as observational studies or randomized controlled trials that did not focus on just population-based studies in describing the overall global epidemiology of pediatric sepsis. So using a somewhat different inclusion criteria, we went on to describe the global epidemiology of pediatric severe sepsis and septic shock. So we started off with approximately 8,600 studies, and after applying inclusion criteria that were somewhat wider than the prior systemic review, we ended up with 94 studies. Among these 94 studies, 51 were from developed countries, and 43 were from developing countries. So what did we find from our systematic review? Well, we found that the overall case fatality rate for severe sepsis and septic shock was approximately 25%. In other words, 1 in 4 children died from severe sepsis and septic shock. From the prior slides, we have a fairly equal distribution of developed and developing countries, as shown by this world map here. And the figure on your right shows the changes in mortality over time among the developing countries as well as the developed countries. You can see from this slide that the overall case fatality rate for developing countries was approximately 32%, and that of developed countries is approximately 20%. So there are differences in terms of mortality rates between different regions of the world. And what is more striking in this graph is, even though there is a decrease in case fatality rate in developing countries, over time, the overall case fatality rate in the more recent years is still higher compared to the developed countries. Let's take a slightly different look at the outcomes of severe sepsis and septic shock based on the different continents around the globe. In continents where there are more developed countries such as North America, Europe, and Australia, the mortality rate was approximately 20%. In contrast, continents where there are more developing countries such as South America, Africa, and Asia, the mortality rate was much higher. Indeed, in South America, the mortality rate was approximately 30%, in Asia, 40%, and in Africa, 50%. When we adjusted for study period, study design, severity of sepsis, as well as age, we found that the odds ratio for death in Africa, Asia, and South America was much higher compared to North America. So in our systematic review and meta-analysis, we demonstrated that there was indeed quite a significant difference in outcomes of children with severe sepsis and septic shock across the globe. And indeed, what we can surmise from our findings is that definitely more attention should be paid to management of severe sepsis and septic shock in certain regions around the world. And although there is a decreasing mortality globally, more can be done focusing on outcomes, improving outcomes in regions such as Asia, Africa, and South America. So now let us change gear and move towards our second learning objective of to describe some of the vulnerable patient groups in our pediatric ICUs that are more susceptible or have poorer outcomes for severe sepsis and septic shock. So I'd like to highlight a study conducted by the NZICS group a couple of years ago, and this is essentially a retrospective multi-center cohort study of children with severe infection. So using the database and data spanning across 10 years involving close to 12,000 children with severe infections, of which approximately 6,700 were invasive infection, close to 3,000 were sepsis, and about 2,000 septic shock. The investigators went in to describe the overall outcomes of children with these infections that were admitted to the ICU. So what did they describe? They found that the most common comorbidities of children with severe infections were that of immunodeficiency or some form of immunosuppression, as well as those with chronic conditions, especially that of chronic neurological conditions, as well as respiratory conditions. When they look at the the risk of death, if you have some of these comorbidities, you can tell from this table that those with immunodeficiency or immunosuppression, as well as those with chronic neurological as well as respiratory condition, had worse outcomes compared to those without. So there are two groups of patients that I would like to focus on in this session. as you have seen in the prior slides, there are other patient groups that are at higher risk of poor outcomes for severe sepsis, but we will not have time to go through each of them individually. So I'll just focus on two groups of patients, and the first group is that of immunocompromised children. And this recent study published in Critical Care Medicine using the virtual pediatric system database in the United States, involving approximately 85 centers in the US, described the risk of mortality in immunocompromised patients with severe sepsis and septic shock. So who did the investigators define as immunocompromised? And they included children with malignancy, congenital immunodeficiency, as well as those that have undergone stem cell transplant. And what did they find? So this table shows the demographics as well as outcomes based on the immunocompromised status of the children. And you can look at this table here that children with immunodeficiency or immunocompromised state has a higher risk of mortality as well as higher severity of illness score on admission to the PICU. And if you look at the mortality rate, indeed the mortality rate of children with immunocompromised diagnosis was much higher compared to those without, 17% versus 11%. So this shows that, just one study shows that, children with immunocompromised state do have a higher mortality rate compared to those without. We do know that not all immunocompromised children are the same. There are various subsets of patients that may behave differently when they are sick or when they have severe sepsis or septic shock. So this figure shows the results of a multivariable model that the authors and investigators from the prior study actually constructed quite elegantly. So in this model, they included important covariates such as age, gender, severity of illness score, as well as immunocompromised diagnosis, as well as history of stem cell transplant. And they wanted to investigate which of these subgroups of patients do worse compared to those without immunodeficiencies. So the first line in this figure, and that's the reference group, is patients without any immunocompromised state. And you can see that those with multiple malignancy, congenital immunodeficiency, as well as hemophagocytic lymphohistiocytosis do much worse compared to those without immunodeficiency. What is interesting is those with stem cell transplant generally do worse even when compared to the same underlying diagnosis. So even if you are immunocompetent after stem cell transplant, your risk of mortality from severe sepsis is close to 5 times higher compared to a patient without any immunodeficiency. And the rest of the red arrows here shows that even after stem cell transplant, for the same underlying oncological diagnosis, your outcomes is actually still much worse compared to those without stem cell transplant. So I'd like to change the focus now to the other subset of patients that I feel that we should start to be more mindful of in our ICU, and these are those with malnutrition. So we do know that malnutrition is fairly common in the ICUs, and up to half of our children are actually malnourished. And in the greater sense of things, malnourished can be either underweight or overweight. And there are numerous studies that show that underweight status is associated with increased mortality and increase in length of mechanical ventilation as well as length of stay. And in terms of obesity, the association with outcomes remains somewhat unclear. So now let's take a look on whether baseline nutrient status can modulate outcomes in our PICU patients, especially that with those with severe sepsis and septic shock. So to answer this question, our team conducted a systematic review looking at baseline nutrition status in the ICU and whether that modulated outcomes. Not surprisingly, we ended up with quite a mixed bag of patients, ranging from those with burns, post-operative congenital heart surgery, as well as the mixed medical PICU patients. By just focusing on the mixed PICU patient cohorts, including those with sepsis and ARDS, we found that patients who are underweight had a much higher mortality rate compared to those of normal weight patients, and the odds ratio was approximately 1.4. So this means that, or this seems to suggest that some of our patients who are malnourished may be indeed somewhat more vulnerable to critical illness and perhaps sepsis. So now let us focus on the third learning objective of our session. And really in the next last 5 minutes of this session, I would like to just describe two management strategies that may be useful in the pediatric sepsis management in beyond 2020. This resuscitation algorithm from the Surviving Sepsis campaign highlights some of the important facets of management in any children with severe sepsis and septic shock. And I just want to focus on two management strategies here because we won't have time to touch on everything. And really, number one, I'd like to touch on nutrition status, and number two, ECMO or extracorporeal membrane oxygenation support in children with severe sepsis and septic shock. So why is nutrition important in pediatric septic shock? Unfortunately, this area is not well investigated, and there remains equipoise about the harms and benefits of early enteral nutrition in children who are fairly stable in terms of hemodynamics. So what we did is that we conducted a retrospective study of children with septic shock and examined the association between early EN and outcomes. And some of the study's definition used in our study is early enteral nutrition is defined as any enteral nutrition started within 48 hours of PICU admission, and we define adequate calories if they achieve 80% of resting energy expenditure by the Schofield equation. So let's take a look at the clinical demographics of the patient group in our relatively small study of 75 patients in total. So you can see from this table here that the non-survivors have a higher risk of mortality based on the PIM2 scores. They have comorbidities that are present more often, and they needed more inotropes. And the day 1 lactate levels or the peak lactate levels were also much higher compared to those who survived. But what's interesting from this study is really shown in this survival curve. So this survival curve illustrates the survival outcomes of 3 patient groups, those with early and late enteral nutrition, as well as those without any enteral nutrition at all. And you can tell that patients without any EN do much worse compared to those with early EN or late EN. And after adjusting for certain important clinical covariates, we found that those that have some form of enteral nutrition did better. Not surprisingly, our energy and protein intake were very low in this group of patients, and we did not find any association between adequacy of energy or protein with mortality. But what our small study seems to suggest is any small amount of nutrition and perhaps even non-nutritive feeding may be of benefit to children with severe sepsis and septic shock. So now let's change and focus on extracorporeal membrane oxygenation or ECMO, and its use in children with severe septic shock or severe sepsis. And so I'd like to just describe some of the data reported in a recent systematic review and meta-analysis published last year. And these investigators included slightly over 20 studies in their review on this topic. So what did they find? So based on the 13 studies that describe pediatric ECMO outcomes, the overall survival of children supported on ECMO was approximately 60%. And when they compared the outcomes of neonates with severe sepsis or septic shock supported on ECMO, this group of younger patients have a much better survival of approximately 75%. Interestingly, when they put all these studies together, they did not find any association between survival and pre-ECMO lactate levels, cardiac arrest, or the need for renal replacement therapy. So this recent systematic review on ECMO shows that in certain subset of patients and children with severe septic shock, ECMO can be offered with relatively good outcomes. And even though one may argue that the survival is only 60%, but we must be mindful that in the algorithm of management, ECMO is reserved for those with refractory septic shock. So perhaps in centers where this support is available, one might want to consider the use of ECMO in children with refractory septic shock. So just to conclude, I would like to remind the participants of this course that we need to be cognizant of the differences in outcomes of pediatric sepsis throughout the world, and definitely more attention can be paid to developing countries. There are certain subgroup of patients in our ICU that are more vulnerable to sepsis, especially those with immunodeficiency, comorbidities, and perhaps those with poorer nutrition status. And finally, just want to remind everyone here that actually management of severe sepsis and septic shock is a team sport, from the first presentation at the emergency department, as well as to supportive management that is fairly important for any patient in ICU, such as nutrition support. All this actually adds up to improve outcomes in children with severe septic shock. So with that, I'd like to thank you for your attention, and I'm happy to take questions in the group discussion later. Thank you.